Ross Milner, vascular surgeon in Chicago. I'm fortunate to be joined by two colleagues today, Celia Riga from Imperial College of London, and with Marc Schermerhorn, who's in Boston as a vascular surgeon. And we're here today to talk about robotic vascular surgeries. As many people are probably aware, most surgical specialties are already performing robotic procedures, which is not true very much within vascular surgery, and especially there's not an indication for vascular surgery. So I know both of you have had some experience with this already, so I'd be interested in knowing sort of status quo, vision, what you look for with robotic vascular surgery.
I think as a starting point, it's important to consider the driver behind this unprecedented adoption of robotics in colorectal surgery, urology, for laparoscopic systems. And if you speak to experienced operators, comparatively to laparoscopic surgery, they will say that the primary driver is operator comfort, operator choice, visualization, especially deep in the pelvis, and also for district general hospitals or less experienced operators, the fact that they can undertake more complex tasks earlier. So the learning curve is potentially short. I think it's important to consider these points because in terms of evidence and outcomes, the data is still limited. But regardless of this, the push is unprecedented. For vascular surgery, I think we have an endovascular setup that is not going to go away anytime soon, and we have to accept that. I'm an enthusiast for robotic endovascular catheter systems because I think there's huge advantages there, not just in terms of radiation protection and being away from the X-ray source, but in terms of maneuverability and stability that allows you to really push the boundaries with the appropriate platform.
Marc, I know you presented at Charing Cross about some experience you've had with type 2 endoleak management. So I think a perfect segue from what we just heard.
Yeah, it was the type 2s that really got me interested in the robotic surgery because they're so frustrating to deal with. It's like whack-a-mole where you do an intervention and then another one springs up and they keep growing. And so this was a way to just wipe out all the lumbars and to do it in a less invasive approach. I had been doing it through an open retroperitoneal exposure using a ligature, getting rid of all the lumbars before opening up the sac to minimize blood loss. And so we've tried to duplicate that now with the robotic experience. I will say, though, that the barrier to entry for vascular surgeons is very high. You have to be board certified, so I can't be the primary operator. I have my partner, Lars Stangenberg, who still has his board certification, probably had some more laparoscopic training because he's younger than I am, and so he's our primary person. He went to Prague, learned from the master, Professor Stadler, and then came back. And I got him together with the thoracic surgeons first, working on first ribs, and then also some MALS cases, and it's fantastic in those cases. And we had a prior surgeon that used to do some robotic MALS, and the results with that are really amazing. Then after that, we partnered also with the urologists and did some vein transpositions, also with a transplant surgeon who had experience with the robot. So partnering together with multiple people. And then on our first couple of lumbar cases, we had the urologist scrubbing with us. But the learning curve is pretty quick for someone who has the laparoscopic skills. And when you approach it in a very focused, stepwise fashion like that, starting off with the easy stuff.
We have two training paradigms for vascular surgery. We have the traditional paradigm with general surgery training first and then vascular fellowship, or an integrated paradigm where you go directly from medical school. So we're going to have to learn. So my partner, who's similar to Lars, as you mentioned, my partner, Ashley Williamson, she did a bunch of robotic surgery as a general surgery resident before doing her vascular surgery fellowship. So for her, this is relatively straightforward. We don't have an integrated program at our institution, but for places that solely have an integrated program, we're going to have to start to incorporate this into the training. And I think an indication is going to be necessary, but interested in your opinions.
So in the United Kingdom, vascular surgery became an independent specialty. So the vascular residents no longer have to spend a year in general surgery. That's after they've completed the core surgical curriculum. I am the head of school for postgraduate surgical training across all surgical specialties across all London hospitals. And it's interesting because despite the push for robotic technology, laparoscopic robotic technology in every single hospital in the UK, it still does not feature in the general surgery curriculum. And it's unlikely to feature for at least another 5 years. Now, having said that, I truly do not see it being introduced in the vascular curriculum because, and we have a very long training program. It's 6 years just for the highest surgical specialty training. And that's outside of any time taken for research towards a higher degree. And usually it spans 10 or 15 years in postgraduate training. And as you would appreciate, it's very, very difficult to convince residents or the societies to introduce robotic competencies in laparoscopy beyond what we expect them to do for open surgical competencies or endovascular competencies. So I don't see that happening. It will probably be in a sort of post certification setting as a fellowship, which is again why I feel there's an opportunity to look to see, rather than looking for an application for a system, because it's not a technology, it's a specific system that we're talking about in vascular surgery. We should also, as a group of vascular surgeons, be saying, well, how can robotics actually enhance what we do currently, which is why I think an endovascular platform will be extremely useful.
We can't be, as more senior people within the specialty, having a negative opinion of the benefit of this technology. Now, it may not replace open, it may not replace endo, but I think to your point, there are going to be certain procedures and certain things that we do that this may have an advantage. And if we're not willing to accept that, like other surgical specialties have, we're going to continue to be left behind in what we can offer our patients.
How many cases do you think, what's the learning curve for robotic laparoscopy? And I mean, I can tell you the number that tends to be picked out of a hat usually, but it's about 30. And it's interesting because one of the concerns that residents in the United Kingdom have raised is that they are unable to get exposed to the training currently because the senior clinicians need to be trained, and there is this reliance on, again, as you explained, on a different colleague from a different specialty that has the experience to get you up to that level where you can be independent.
Mm-hmm. Yeah, and I think it shouldn't be the most senior of us just because we are that much further away from laparoscopy. I think we as a specialty did a great job of seeing the future and jumping onto the endovascular wagon quite early. And I think we were better than most specialties, but I think at the same time, that probably slowed us down from advancing our laparoscopic and robotic skills. And I think now we need to, again, see the future and make it happen and make sure that we're a part of it.
Yeah, I think that you're so spot on with that statement, right? Because I think what a lot of the other surgical specialties, when they look at laparoscopic robotic, that was their less invasive technique.
Correct.
Our less invasive technique was endo. But we're also really the only surgical specialty that can do big operations and can operate in almost any part of the body and still have the skill set with wires and catheters. So we offer a lot. This is just another part of what we potentially can offer patients. And the way that I've been thinking about it is it's not really meant to necessarily replace anything we do right now, but it's just a way to potentially have another option to take care of problems that we don't have great solutions to.
My question would be, do you feel that from an endovascular perspective, the technology that we're all using at the moment has reached its plateau? Do you think we're performing endovascular intervention as well as we can, or can it be improved?
I think it's going to be all of the above there. I think that endo has a long way to go. I think, we need to get rid of radiation, whether that's using, fiber optics or MR developed techniques. And then also, I think just like the robotics can, get rid of the tremor when we're doing the laparoscopic surgery, it can also fine tune the manipulation of a catheter and a wire, a steerable sheath, et cetera. So I think there's a bright future for it within endo as well.
I think about an endovascular procedure right now that's a relatively straightforward EVAR, infrarenal EVAR, but how we struggle, as you're saying, with type 2. So is an infrarenal EVAR going to become now an infrarenal EVAR with a robotic ligation of IMA, with a robotic ligation of lumbars as part of the initial procedure? Are we going to get to that point?
I don't know.
I don't know either.
Yeah, I think it's also worth thinking about customization of stent grafts, because robotics has really taken over the manufacturing industry, not just in healthcare, but outside of healthcare. And when you talk about, physician-modified grafts, inside fenestration, device conformability, again, this is something to think about in terms of how can you customize something very quickly for each patient as they're coming into the operating theatre. So I think there's a lot to think about, and industry should be taking into consideration how robotics can enhance, their markets.
What do we need additional? What kind of studies? What kind of data do we need to get a type 2 endoleak indication, or for different procedures, or will just a general vascular approval process be sufficient?
My own thought is that we need to put people together that are interested and that are doing these procedures, letting them share experiences, outcomes, tips, techniques, and pool data. And then once we see how the data look when they're pooled, then we can figure out where it's most optimized and where we should be going for an indication. I suspect that's wherever we gather the most data first, where things look good, and that would be the first indication, but potentially even putting together a package of procedures with, varying levels of experience and outcome data. But I mean, so far the outcomes look really good.
I agree. I think for laparoscopic robotics, safety and feasibility, choose a procedure that actually might lead to measurable benefit, for example, reducing infection, as you said, or reducing reinterventions or endovascular procedures that increase the number of reinterventions. But I think also it will be important to understand how long does it take to train and to achieve competency. I think this is key. On the endovascular side, the system that used to be available 15 years ago was probably the most advanced from an electromechanical perspective. These days, most people would use, an Aptus sheath or a steerable sheath, which is a poor man's robot, does the work well, but not well enough, perhaps, in terms of the capabilities of the original platform. I think to justify the cost, you will need to have a platform that combines both imaging and the mechanical properties of catheters. Existing platforms at the moment have reduce the cost by providing a robotic arm, a driver that allows you to use off-the-shelf catheters and sheaths. So this is what is currently available. And as much as this has the potential to reduce radiation, if you like, I don't think it has the capability of the original platform in terms of stability.
So final comments, final thoughts. What do you think?
I think clinicians with experience, or those who are interested in pushing the boundaries, should work with engineering specialists and industry to come up with a product or products that would actually benefit our practice and enhance our practice, and incorporate both sort of the advantages of open surgery, but with minimizing incisions, but also the endovascular revolution that is here to stay.
I would just say, with the revolutions that are going on with AI, I think robots are here. They are going to be part of the future, and we need to adapt so that we're at the leading edge of that future.